Schau, da ist er ja. Hello.
Good evening, Prof.
I think we are live and can start.
Well, if we are if we are live, I would like to say hello to everybody, to the people listening to this webinar, and I would like to start by apologizing for my voice, but it's not my brain, it's just the voice. I had a hard cough, and now it's a laryngitis, and it's hard to speak. I would like to announce the seminar on mild TBI, a silent pandemic, as the headline is talking about. And we have 4 contributions. And we are scheduled for 15 minutes each for every presentation. And the first presentation will be given by Sophie Richter from Cambridge. She is a specialty registrar in emergency medicine, and she's talking about mild TBI and neuroimaging. And before she starts, I would like to remind you that it would be, if you would like to discuss further on after the presentations, you should check your Q&A box and write into the Q&A box your questions, your comments. The chat is mainly to say hello and for further communication. So again, with my apologies, now we start with Sophie, and she's talking about mild TBI and neuroimaging. Anna, can you start the presentation, please? What else should I do? Anna?
Now it starts. Okay.
More specifically, for how the future of mild traumatic brain injury might look like in terms of its neuroimaging and its assessment in the emergency department. My name is Sophie Richter, and I'm a specialty registrar in emergency medicine in Cambridge in the United Kingdom. I'm also doing my PhD on neuroimaging for traumatic brain injury. This topic is actually very close to my heart as a clinician, because traumatic brain injury, and particularly mild traumatic brain injury, is so common that we see about 1 million patients with it in the emergency department every year. So for an average shift for me, that means I see about 1 patient per shift. But also on a personal level, because traumatic brain injury is estimated to affect about half the world's population at some point in their lives. So that means probably all of us either have experienced a traumatic brain injury ourselves or know somebody that has. Out of all traumatic brain injuries, the vast majority of those are the mild traumatic brain injuries. So that's those patients that present to the emergency department conscious with their GCS of 13, 14, or 15. They can be caused by a variety of causes. Most commonly, it is road traffic accidents and falls. It can be assaults, sporting injuries, or military injuries as well. So I'm just going to illustrate for you as an example the patient pathway here in the UK, but it's very similar across Europe. So the patient attends the emergency department, and If it's a more severe case of TBI, then obviously they get admitted to the hospital and receive adequate follow-up and rehabilitation after discharge. But the majority of patients we see are the mild traumatic brain injury cases. And the first decision we have to make for them is whether we CT them or not. So each country and sometimes each hospital uses different criteria to make this decision. In the UK, we use the NICE criteria, which are based on the Canadian CT rule. And we end up scanning about 20% of our patients. However, the vast majority of CTs are normal. So between 85 and 95% of CTs end up being normal. So only a very small portion of these patients actually have any abnormality, which means that we would admit them either because they require neurosurgery, say for an extradural hematoma, or because they we just want to observe them overnight. So the majority of patients we send home, either with or without a CT, just give them some safety netting advice, some concussion advice about what to expect in the next few weeks. Yeah, we think they will get better, which we now know is often not the case, but I'll get to that later. So the first concern we have in the emergency department is how we can reduce the time patients spend here. Already before COVID, but even more now, we struggle a lot with the emergency department crowding, and every little helps to reduce waiting times and congestion in the department. So here's a study conducted by some colleagues in my group who have developed a machine learning algorithm that can actually automatically report the CT of a patient without requiring a radiologist actually manually reading a CT. So that is an interesting prospect for the future of TBI management. So the way we use the CT at the moment is just to decide, if there's something to see on the CT, we refer to yourselves, to the neurosurgeons, for observation, potentially intervention. But we thought, okay, so those with a positive CT, they have a risk of severe disability or death, like this classic patient with an extradural hematoma. But we generally assumed that within that all patients with a normal CT or those that didn't even qualify to receive a CT will recover from their symptoms within the next 2 weeks. So here's how we would manage them, right? The black patients we would admit to neurosurgery, and the white patients we would discharge without any follow-up. However, we now learned that there is another shade of gray in between, and that's those patients who don't have anything abnormal to see on the CT, and yet they have persistent symptoms. They really suffer for the next even 6 to 12 months and don't return to their baseline functional level. And how do we know this? Well, we had in recent years some high quality prospective cohort studies underway. So in the US, that was the TRACK TBI study. They've looked at more than 1,000 MTBI patients and found that about half have not completely recovered 1 year after their injury. So it's all mild TBI patients. Then in Europe, of course, we had the Center TBI study. They looked at about 800 TBI patients, and they were not just mild patients, but actually patients that were mild and discharged from the emergency department the same day. And of those, 30% still had symptoms 6 months after their injury. And also there was the Upfront study conducted in the Netherlands, and they looked at about 900 patients, and 44% of those still had not recovered completely 6 months after their injury. So if you now look at the top part of this patient pathway, then we know actually after we've sent the patient home, a huge number of patients go on to have symptoms that will interfere with their recovery, that will interfere with their everyday life. So these sort of symptoms are often referred to as post-concussion syndrome, just to reflect that they span a broad variety of symptoms ranging from cognitive to psychological and somatic symptoms. And they really interfere with the patient's lives. So a review has shown that 2 in 5 patients at 1 month and 1 in 5 at 6 months after a mild TBI have not returned to their work because of the TBI. So as emergency physicians, we are very bad at trying to predict outcome. So there was a survey of emergency physicians that had to judge what they think the outcome of their patients would be. And in about 90% of cases, the physician thought, oh yes, this patient's going to do well, they will be fine in 2 weeks' time. But actually that was only true in 50% of patients. Half of the patients still had symptoms. So we need something better than flipping a coin, something better than our sort of clinical gestalt or intuition. Yeah, so previously we discharged the patient just with advice, but now that we know that they won't all recover spontaneously, we should really look into why they don't recover and what we can do to change this trajectory. So really the key question is, can we predict who will have persistent symptoms? And as I touched upon earlier, the CT is not that helpful in differentiating between patients who will and will not go on to have symptoms, because often the patients have a normal CT even if they go on to have long-term symptoms. What seems to be more helpful, we find now, is magnetic resonance imaging. So that is often abnormal in the patients that do have symptoms for a long time. So what I mean by magnetic resonance imaging is not just the standard clinical sequence that can then be reported by a radiologist for the presence or an absence of a visible lesion, but what seems to be particularly useful is quantitative MRI. So quantitative MRI can be done on different types of sequences. We have structural sequences where we might be able to extract the volume of different brain regions. Say, for example, look if there has been any swelling or atrophy of the white matter after the injury. And also very promising is diffusion tensor imaging. So that's a way of looking at the integrity of the white matter and measuring that in quantitative metrics that get extracted, again, not by a radiologist reading the CT scan, but by an imaging pipeline. And that can give us a measure of the integrity of the white matter. So a study earlier performed by our group showed that an MRI in this mild TBI group is indeed prognostic. So here you can see the association between an MRI scan, and that's a quantitative MRI scan, and the patient's outcome at 3 months. And in particular, we were here comparing the timing of the MRI to see if it makes sense to scan the patient as early as possible. That's within 72 hours. Or whether it's okay to wait a couple of weeks, which is logistically much easier to organize. But actually, we found that it's really much more informative to scan the patient as early as possible after the injury. And again, touching up on what I said earlier, we compared different types of sequences. So we looked at the standard clinical MRI, and that added a little bit of information extra to just using demographic information. But really, it was this advanced quantitative MRI using quantitative measures of the white matter volume and the white matter integrity that really gave us the best prognostic information for each patient. Now, the issue is that while MRI is very promising in the research arena, it's just too challenging to implement in clinical practice. It's costly, it's not widely available. So if we really wanted to use it as a tool, we would have to triage access to it, select which patient can have the scan, because we can't scan 1 million patients every year. It's just not feasible. So what has been the thought is that one could use a blood-based biomarker, so some protein that gets released by the injured brain that could then indicate whether or not the patient might benefit from an MRI. So a little bit like we are using a D-dimer for pulmonary embolism or troponin for a heart attack. So here's a paper released by the Track TBI group, and they looked at using exactly that, using protein biomarkers in order to predict which patients will have an abnormal MRI and a GFAP, so a clear fibrillary acidic protein sampled within the first 24 hours. So basically when the patients present to the emergency department, can help to differentiate which patient would likely have abnormalities on MRI and could help to triage patients for the MRI. Okay, so that area still needs some work, but there's some promise in that we might be able to predict which patients go on to recover and which patients don't. But that's not really good enough, because once we've identified which patients are at risk of a poor outcome, we would really want to intervene and treat them. So we want to know a little bit more about the patient's symptoms. Now, that's very difficult to get the sort of high resolution data, especially in the emergency department where the bulk of the MTBI patients present. That's because it's very resource and time consuming to do face-to-face neurocognitive assessments. They're just like too many patients to catch them all. And the loss to follow-up is really significant. So mild TBI studies compared to any other TBI studies show the highest amount of patient attrition. We're just struggling to effectively follow them all up. So there's something we're piloting in Cambridge, and that is a mobile app for patients. They can use that app in the waiting room, and it works two ways. So the patient can receive tailored information depending on the symptoms they put in, and that way they don't get cognitive overload from too much information. But equally, they contribute data that can be used for research and then inform decision making for similar patients. And again, that makes it easy to actually repeatedly follow the patient up after discharge. They don't physically have to come in face to face. They can do the neurocognitive assessment in regular intervals after the injury occurred. So as I said, that sort of benefits both the researcher and the patient. And we are hopeful that this way we can gather some more high resolution data and actually link the cognitive and psychological symptoms of the patients with the MRI data, and then find a correlation between what we see on the imaging and how the patient actually performs on reaction time tasks and depression scores and so on. Yeah, so we are hoping to roll this out soon, but the start has been delayed as everything by the pandemic at the moment. So to summarize the future pathway for TBI, that that we envisage, that we are hopeful for in the future. Multimodal assessment using blood protein biomarkers, using a mobile app for neurocognitive and psychological testing, and using advanced magnetic resonance imaging to better characterize the patients. And we are hoping that can improve the patient experience because they have to wait less and they get more information. It can improve triage for follow-up, and hopefully this way improve the outcome for the patients, and also better understand the pathophysiology of what's actually going on in the brain after a mild traumatic brain injury. And as we would then be able to better predict which patients are in high risk of poor outcome, we can select those specifically to enrich clinical trials, and hopefully in the future derive some treatment for those patients. So thank you very much for your interest in this talk. If you have any questions or would like to work with us, we are very keen to hear from you. So I've left our contact details here. Thank you very much.
Thank you very much, Sophie. I got the information that Sophie is not so far available right now for discussion, but the 3 questions put in the Q&A box can be discussed also amongst us, I think. For example, Jack Barrett is asking, MTBI patients with persistent symptoms, are these particular patient groups? For example, young road traffic accidents or elderly patients with falls. What is your so far impression and cognition? Aurelia, Alexander, Iftaka.
Alexandria, maybe I start with a young patient. I think those who are functionally fit recognize their deficits quite easier than those maybe older patient after falls. So I think it depends on the requirements for your daily life, and the fitter you are pre-trauma, the more you experience deficits afterwards. And I will focus on that during my pediatric talk, so I don't want to go into details now.
So I also wanted to maybe add that, in my opinion, it's not about different patient groups. More so, the persistent symptoms probably depend on injury mechanisms and predispositions and other co-founding factors. So I don't think that you can essentially say young road traffic incidents are in general at a higher incidence for persistent symptoms, but you rather have to look into details, and there are ways, models to try to identify patients at risk for those symptoms. And it's not necessarily only young or old patients, but it's several factors. But I think not all factors are understood yet. So there's a lot of, hopefully, research going into this to identify which patient actually is at risk for those symptoms.
Iftaka, any comment from your side? You have to unmute. Can you unmute?
Yeah, sorry, can you hear me now?
Yes.
Yeah, I think it's really important that, as Alex said, also evaluate it as a multimodal component. We need to also think about the pre-injury health of the patient. I think that's really important.
Okay. Well, I had a question to Sophie, which will not be answered right now, but for me, the essential question is, are there consequences if we diagnose, by what way ever, if we diagnose incomplete recovery? What to do, how to treat? Because if we tell somebody you are not okay right now, you can't work, you can't do your normal job, this is certainly also not helpful, especially if we can't offer a special treatment. Does anybody know a program,
Yeah.
for example, to improve neurocognition, to improve faster thinking?
So I, for myself, as a neurosurgeon, I mean, probably that's the same question I would ask and I have asked, and I wasn't aware of one, because when we see the patients in Germany, at least, we tend to discharge them without giving them a certain, portfolio of things they might could do at hand in case they develop such symptoms. But in preparation of my talk, I'll briefly touch on this later, I found various methods that can be used to improve such symptoms, and I can only say that the evidence for any of them is really low, and that there is not, I mean, there's weak recommendations for some of them, but it goes from visual therapy to music therapy to, of course, physical exercise and medication. And so, but I'm not aware of any specific program, at least in Germany right now, that could be given to the patients. So that's a good question, I think.
Okay, and this is also a question for me: what is the benefit of an early advanced MRI? It costs a lot, and maybe for insurance companies, it's important to regulate legal issues or so. But for treatment so far, it is not really helpful. But these are open questions, and of course, the future will tell us how to go. Well, there are further questions. Unfortunately, I think we should move on, because there are also two questions about biomarkers, and the next contribution by Iftaka Hossain from Turku in Finland will be on biomarkers, and we can certainly discuss the issues of biomarkers after his presentation. So Iftaka, it's all yours.
Thank you, Prof. Thank you, Prof, for moderating the session. Prof, could you see my screen, please?
Yeah.
Okay. So today I'm going to talk on the biochemical diagnostics of mild traumatic brain injury, the current state, and the feasible future. I have nothing to declare. So at first, as Sophie discussed earlier, if we think about the current diagnostic methods of mild traumatic brain injury, how do we diagnose this? As all of you know, the assessment of consciousness level, medical history, neurological examination, and the traditional neuroimaging tool, most of the time the CT, and if needs, then the conventional MRI. We have the prognostic tools, the outcome measures, so well-known, GOSI and other methods, but the CT scoring system and prognostic methods mostly under research. And do we have any single specific tool for diagnosis and evaluation of prognostic of MTBI? Most possibly the answer is no. We know about the GCS, but it has the poor ability to predict neurocognitive outcome. It cannot tell us about the brain herniation if we don't check the pupils properly, and not ideal for tetraplegic patient. And CT scan, we know that it's insensitive for identifying DAI. And other fancy MRI tools could be good for research, but most possibly, as Prof also mentioned, not adequate or perfect for the current situation of MTBI. So as Sophie discussed earlier a bit that about the other fields of clinical medicine, we have different like troponin, CRP, HbA1c. But for TBI, do we have any adjunct things to do to understand the disease better? It's still clinically no. So what is a biomarker? I'm not going to tell the whole definition, but as you know that it is an objective measurement, what will give you the idea about the biological process, pathological process, and also the treatment response. And if you go through a little bit about the proper qualities of a biomarker, it should be highly sensitive and specific. It should help us to stratify the patient's severity of injury. It should be easily available according to the disease condition and infinite passes via the blood-brain biomarker. And it should have properly characterized biokinetics as well. And it might aid in the prediction of functional outcome. So what about the diagnostics role of biomarker in TBI, or do we need thing? We need the biomarker to stratify the different diseases, to stratify the severities. And secondly, verification of patients with TBI having concomitant injuries. Can we identify a patients having MTBI and other concomitant injuries by a biomarker? And another thing is important, we know there are several confounding factors what could have an impact on the consciousness level. Can biomarkers help us to understand why the consciousness level is low? Is it due to intoxication or it is really related to brain injury? And about the prognostic rules, it's important. Can we use it in the ED or when as a trainee neurosurgeon or a neurosurgery consultant, we're going to see a patient? Can we use a biomarker to realize who needs probably follow-up or observation, and also to understand different pathophysiological processes happening in the brain? Can we have panels of biomarkers? Because the brain injury is not a single cell injury, it's having the single supporting cells injuries as well. So to understand the pathophysiology of traumatic brain injury. So it's a very famous pictures coming from the publication of Prof. Zetterberg. So if you see that the biomarker coming from the nucleus, this part mainly in the studies are UCHL1, and from the astroglial cell, most well known S100B and GFAP. And the biomarker indicating the axonal injury, most well known is the NFL, and which are coming from the axon terminals, indicating neurodegenerative diseases, especially for the concussion players. It's the tau protein. We'll go through these things in coming slides. And if you have a look here, so this maintaining the time, the x-axis and the y-axis, talking us about the different protein biomarkers. And every biomarker is related to the phase of the disease. The first phase, the biomarkers is indicating the necrosis and the going through the axonal process, and the subacute process, apoptosis and demyelination, and the chronic biomarkers talking about the progress of diffuse axonal injury. And the current studies tells us about the standard idea of the kinetics of the biomarker, what is really very important, because we need to know when do we need to test. If we do not know the kinetics of the biomarker, then we can publish a lot of papers, but it will not translate to clinical practice. And so what do we know currently? Currently, S100B, it has been incorporated to the Scandinavian guidelines. It could help us to preclude need for head CT according to the cutoff values. We'll see it in the next slides. And there is some contradiction about this incorporation in the guidelines, but most of the studies show that it works. We can exclude the patients who do not need CT scans according to the S100B cutoff values. Especially in this case, the good point is that it also includes the idea of extracranial injuries and other confounding factors. And if we think about the GFAP and UCHL1, what is the evidence for ruling out CT? So it's one of the important studies or the hot cake studies telling us about the allowed TBI. It gives us the idea that high sensitivity and negative predictive value of GFAP and UCHL1 test support its potential clinical role for ruling out the head CT need. Well, science has been always criticized, and it is an important point here to see that is it a big progress? Of course, it gives us an idea that the GFAP could help, but here GFAP and UCHL1 has been used together. But unlike the Scandinavian guidelines, the FDA-approved test does not consider clinical covariates, for example, extracranial injury or other clinical factors like GCS and injury mechanisms and other drugs. And need to know that GFAP is not yet included in any clinical guidelines. So another important study, currently we know that the main two biggest studies collecting data from all around the world, track TBI and the center TBI. So this is an important study where it has been showed that plasma GFAP concentration, it correlated with subacute and late MRI abnormalities for CT negative patients. It means that it could help us to understand the pathophysiological process following TBI, and GFAP could indicate the patient could have CT negativity, but might have progressive injury, and it could be used within first 24 hours of injury. And the current studies, if we go through, this is one of the important studies, again, by the Track TBI group, that if we compare the GFAP with other biomarkers, especially S100B and UCHL1, GFAP was superior to UCHL1 and S100B. Again, it has been studied by the point of care platform here. It has been again showed or scientifically proved that GFAP could be better compared to S100B. And we have to remember that S100B is not specific when there is concomitant orthopedic trauma. And this is an important one reported by the Center TB Hooks group, that blood biomarkers on admission in acute traumatic brain injury, if we compare GFAP with UCHL1 and S100B, then GFAP correlated strongly with the CT findings. What again says that GFAP could guide us to know if there is a brain injury in case of mild TBI patients. So what about the prognostication? We always talk about the diagnosis of mild TBI. What about the mild TBI prognosis? Do we know that whom we should follow up, whom we should observe more, who should come for neurorehabilitation? The answer is still we do not know. We do not have any class 1 evidence. So NFL, the biomarker coming from the exons, it has been studied that for repeated mild TBI, NFL strongly correlated with the late DTI findings. So yes, DTI is a fancy tool to understand or to study diffuse axonal injury, but in every setting around the world, we cannot do DTI just to study the mild TBI patients, but an acute NFL level would help us to understand if there is any changes following repeated traumatic brain injury. And we have reported from Turku with our Cambridge colleagues that early levels of and NFL, especially NFL, could differentiate complete and incomplete recovery, and it correlated strongly with the outcome. But I have to say that in this study group, the result was mostly driven by the more severe injuries, because we had MTBI patients who also had to undergo surgery for their conditions. And then finally, this is an important study coming from Shamim's group from the United States. Here they have studied NFL, Tau, GFAP, and UCHL1, and correlated with the late neuropsychological test and the DTI imaging. And NFL, again, was better than Tau, GFAP, and UCHL1 for the chronic TBI patients. So finally, the neurodegenerative biomarkers. So when you talk about MTBI, you also cover, as you know, the concussions. So this is one of the important studies from Prof. Marklund's group, that neurofilament light and Tau, if you compare them as blood biomarker for sport-related concussion, NFL was better than Tau, but Tau is still having promising results. But have to say that most of the concussion studies were done with sometimes CSF sampling, but I believe that, in my opinion, a patient coming in the ED, it is probably not feasible all the time to do a CSF sampling. Probably the plasma sampling would be the ideal one. And then this one of the studies, we also studied about Tau and amyloids to understand their changes as chronic traumatic encephalopathy and also the mild TBI symptoms. We have found that Tau here was better than the amyloids, and Tau correlated with the outcome. But the fact is that we studied total Tau, so future studies we need to study on the prophylactic Tau, because the total Tau did not have the proper outcome measurement results. And in future, it's a very probably, I would request all the people who are listening to this that it would be a very good systemic analysis done by Prof. Menelo and Prof. Buki, where we come to know that, yes, we have published a lot of papers, but what about the clinical translation? So we need to avoid some important things, the biased reporting, that's very important. And biomarker measurement variability, we cannot compare one study with another study because the measurement analyses were different, poor study designed, and inappropriate target groups. We need to really define that, yes, going through the scans, this is really mild TBI, not like mild TBI having a concussion or needing surgical procedure later, and inadequate analysis. So to conclude, I think we could tell, not strongly yet, we have to look through all the coming studies from Center TBI and Track TBI. GFAP could be cost-effective single biomarker approach to understand who needs a CT scan in the ED. And further evaluation of panels of biomarker needed. The current study showed we were so much hopeful that panels of biomarker will show better results than single biomarker, but the reality that Center TBI analysis showed that panels of biomarker in case of diagnostic was not superior to single biomarker, but we need to see how it will work for prognostication. NFL could help to stratify DAI. We are working on Center TBI. How the results come, they show that it is pretty promising. And then we have to work on p-tau, would have potential for concussion biomarkers. And finally, development of standard assays and point of care device. We would like to use it on the rugby field. So we need to improve the standard method, what is accessible everywhere, and the point of care device and inclusion in prognostic model. We have impact and crash models for severe TBI, but what about mild TBI? Probably we need to do more studies incorporating the biomarkers for mild TBI and integration to clinical decision-making, because at the end of the day, we need to think about the patient, to know the history of the patient, examining the patient, and biomarker could be the adjunct tools. And we'll see how the also Center TBI comes. And thank you very much for your patience to listen to me. Thank you. I'm very happy to answer the questions.
Well, thank you very much, Iftaka. Great talk. And you tried to bring some light into the confusion of significance of biomarkers, which is difficult, as we all know. I had a look at the Q&A box, and there are some remarks, and I would like to let you know that, for example, Peter Bieberthaler from Munich, he put in some comments already for Sophie's talk. I'm pretty sure that he also listened to Iftaka. He did a lot of studies concerning biomarkers in mild TBI. My question to you, after this conclusion, Iftaka, is it time already to include biomarker diagnosis into guidelines, like in Scandinavia?
I think, Prof, it will depend. Thank you for your question. I think it will depend also on the country's socioeconomic condition. But if we think about brain trauma guidelines, everything, probably we need a consensus, because different studies are telling us different things. And at the end of the day, we are telling that, yes, we are using different. The population is not ideal yet. Probably we should come to a consensus. And if the consensus says that, yes, it is the time, then it might be helpful as a tool.
Yes, but the problem is, of course, as you cited, Stefania Mondello's review, which is a living meta-analysis. So ongoing new results will be fed into this analysis, and then it will change over the years. But there are so many different biomarkers, so many different time points, intervals, different subsets. Do you really think that in the near future we'll be able to sort out which group should receive which testing?
I think, to be honest, I'm quite hopeful about NFL and GFAP. I think that if the Center TBI results, because it is probably, as you know, Prof, the biggest study cohort. So I think if Center TBI coming study shows us that, yes, GFAP and NFL could guide us to understand GFAP for CT who needs or who do not need, and NFL for prognostication, then might be, why not?
Okay. There is another comment by Peter Bieberthaler, and he says, all the initiatives searching for mild TBI markers to improve CT indication have shed some light into this black box, which is true. But on the other hand, nowadays we are not just looking for CT indications, but already for sophisticated MRI indications, which is also a problem. Okay, again, many thanks, many open questions to solve yet, but we have to continue. And the third presentation will be given by Aurelia Perrault from Ulm in Germany. And Aurelia is a pediatric neurosurgeon. So she will present mild TBI in the pediatric population. Please go ahead.
Thank you. Thank you, Mr. Unterberg. Thank you for the opportunity to guide you now more into the pediatric world. And the pediatric brain tumor is a silent epidemic or pandemic, as the title of the webinar says, and the incidence is varying depending on which study you're looking. Around 200 per 100,000 children are younger than 15 years of age. And the best thing is to prevent TBI by helmets or sufficient restraints in core. And the lower two boxes show you where the injuries take place. Most of those occur at the street, at home, or in sport. And most of the injuries are caused by road traffic accidents or by falls. And the age groups that are mainly involved are those younger than 4 years of age and the teenagers. And you can imagine falls are more prominent in the small ones and road traffic accidents, especially in the teenager group. But is the GCS a predictor for the severity of the trauma? According to the publication given here on the right side, GCS is a strong indicator for the outcome, not only for mild, but also for severe TBI. And according to what we know, most of the trauma or most of the TBIs are mild according to the GCS. And I put 14 in brackets because there are also colleagues who consider mild TBI not including a GCS of 13. But even mild TBI can have tremendous effect on the child, and that depends on the age of the patient and also on the trauma mechanism, and the awareness is increasing. But what does minor mild TBI mean? I don't want to confuse it too much, but the definition is for sure not a common one. There are, the American Academy of Pediatrics says mind closed head injury. When you look at the American Congress of Rehabilitation Medicine, it's a mild traumatic brain injury, and even concussion is included. And the World Health Organization has defined mild TBI as an acute brain injury resulting from mechanical energy to the head, and includes one or more of the following criteria: confusion or disorientation, loss of consciousness for more than 30 minutes or less, post-traumatic amnesia for less than 24 hours, and or transient neurological abnormalities, focal signs, seizures, intracranial lesions that are not necessarily requiring surgery. But including already obvious lesions would mean maybe it's more a complicated mild TBI, not an uncomplicated mild TBI. And of course, the Glasgow Coma score is important and should be between 13 and 13 minutes after injury or at presentation at the emergency room. I don't know why this does not change. So this is an interesting study, and also confirming that what Sophie said at her first talk from Ash Single from Vancouver concerning the indication for CT scan in children. When you see that 70 to 90% of head traumas are mild, only 4 to 7% have an injury on CT scans when you look at the pediatric population. And a clinical important injury occur in less than 5%, and those requiring neurosurgical interventions are even less than 1%. So there is an overuse of CT scans in children, and this is even more important when you consider the deleterious effects of radiation exposure to a developing brain. So consider MRI images, and we already heard the talk. There you can detect even subtle signs of trauma. Why is the head of a child more vulnerable than in the adult setting? I mean, the head is less, the brain is less myelinated, and the younger the patient, the more the propensity exists for developing a trauma, a TBI after trauma. The children are even more likely to develop a diffuse axonal injury. They're not so prone for space-occupying hematoma, except they have bleeding disorders, or it's an unfortunate fracture occurring. And it's also sometimes very difficult to judge children depending on their age. They can be difficult to evaluate. Lethargy or irritability or even anorexia can be a sign for a trauma, and for also tense fontanelle or sunsetting signs, or even late signs for significant trauma. And when you look at children below the age of 4 years, communication can be tough in those kids. And not only are they difficult to judge, but they are also different in depending on their age with regard to the trauma location. When you look at the picture on the left side, a child is hit on a different area by a car than an adult patient. And so the area of impact is different depending on the age. And when you look in here, you can imagine that the head-body relationship also makes a big role with regard to trauma consequences, with having a big head on a tiny body with a loose connection. You can imagine a whiplash injury is more likely than an adult patient. The facet joints in the cervical spine are more shallow, and the muscles of the neck are more weak. So this also contributes to the importance of kids. And you have a growing skull, as you see in here. Fractures are different depending on the age group. You have more like a linear fracture or green stick fracture in the very young, and not involving so much sinuses. But this has to be considered in the older ones, and even fractures to growing teeth needs to be considered. This I already showed. But what are the factors that lead to referral to specialized centers? And this is a study taking into account the PKERN criteria. So seizures without having an epilepsy history before, or prolonged consciousness of more than 2 minutes, focal deficits, signs of a depressed skull fracture or a tense fontanelle, or other signs of skull base fractures are important criteria for admission to a specialized center. Decreased sensorium, and also the trauma mechanism is important. Prolonged confusion, headaches, or patients who are under anticonvulsant, under anticoagulants, and this is not unusual in some kids, especially with heart defects. This is the study I was referring to from Kupperman in 2009, and this is the study summarizing the PKERN criteria, which I just cited, giving indications for when a child needed an imaging or not. And in this study, it was a CT scan that was either recommended or not necessary. Coming now to the post-concussion disorder, and this is an interesting article on the symptoms that occur. At least the history has to be known within a time frame of 4 weeks. Patient has neuropsychological difficulties in attention and memory, and 3 or more symptoms that last at least 3 months, like fatigue or sleeping disorders, headaches, dizziness, irritability, and aggression, but also anxiety and depression, and the change in personality can be signs for a post-concussion symptom or syndrome. But not only the symptomatology of the child needs to be taken into consideration, but also injury factors that are prone for post-concussion syndromes, and not to oversee family factors, how the family is functioning after the trauma of a child and how they are coping with the situation. And these are factors that influence the child, how they cope with the trauma, whether they develop symptoms, and finally with their functional outcomes. How many days are they away from school? How is their physical health? Do they have normal sport activities after such a mild trauma? And another large study from Rosenbaum showed that although most kids do recover quite well after mild TBI, 10 to 30% have persistent symptoms that last longer than 4 to 12 weeks after trauma. And these curves should just show you that obviously girls are more prone for post-concussion symptoms, and teenagers are even more prone than younger patients. And those who had already pre-existing symptoms like emotional distress or a migraine history are more prone for post-concussion symptoms. When we look at our own algorithm for the treatment of pediatric patient after trauma, I want to focus on those with a GCS more than equal or more than 14. And those are very important criteria when we do imaging. Is there a progressive decrease in consciousness, or was there a loss of consciousness after the trauma for more than 5 seconds? Do the children have signs of a skull or skull-base fracture like raccoon eyes, battle sign, liquoria? And how was the trauma mechanism? This is an important issue. Was this in an MVA, was the patient expelled from the car, or was another patient or another participant even dead after the trauma? Was it a rollover trauma in pedestrians or cyclists, and did they wear a helmet? And with regard to falls, which is the admission for most small kids, how was the height of the fall? Was it more than 90 centimeters in children below the age of 2, or respectively more than 1.5 meters when they are older? And did any seizure occur, or did the child vomit more than 3 times? Did they complain of progressive headaches, or do they have focal signs? So these are very strict criteria we consider enough for post-trauma imaging. And whenever possible, we do an MR scan, or in the smaller ones, we check by ultrasound through the open fontanelle. And we are even more reluctant in the small ones who might have obvious signs of an hematoma on the skull, especially when it's in the occipital temporal parietal region. And we also consider the parents' estimation of the trauma and the behavior of the child, whether we do an image and survey the patient for at least 24 to 48 hours or not. If those symptoms do not exist, and if the child is older than 2 years, we do not do any imaging. Maybe we admit the patient just to make sure. And with this said, I hope I could show you a little bit that the definition of mild TBI in children is, in my opinion, not clearly defined. And they are more susceptible to trauma, especially the ones under the age of 2 years. The overuse of CT scans should be avoided, and whenever possible, an MR should be done. Child and family factors, and as well the trauma factors, can influence the occurrence of post-concussion symptoms. And I think it would be important to have a treatment algorithm that, to make the clear decision in the emergency room or in the trauma setting. Thank you very much for your attention, and I'm open for questions.
Well, thank you very much, Mrs. Perrault. This was really great. And I forgot to mention that Aurelia Perrault is one of the very few pediatric neurosurgeons who is also professor of pediatric neurosurgery. And this is really my respect.
Thank you very much.
Mrs. Perrault, my question, you were asking for treatment algorithms, and German parents love to follow rules or recommendations. If you send them home, their children, and you say, take your children home, they just got, luckily, a mild TBI. Would you send them back to kindergarten, to school? Who is deciding which kids, which youngsters should be taken out of school, out of kindergarten for a certain time period?
Well, when we send them home, we only do that when we are really sure that mechanism was not severe. The child didn't have any symptoms that would consider that we consider they could develop post-concussion syndromes. But you're right. We have a little leaflet for the parents with recommendations. If they go home, they should watch for this and this and this symptom. And we always do see kids again. This is a lot of work, but we always see them again a few days later, and if necessary, in a longer follow-up sequence. Especially the youngest, they are prone for unrecognized symptoms later on, like also hydrocephalus.
Okay. Are there any other questions from the two other speakers, for example? Because in the Q&A box, I could only find messages to the previous presentations, but I will check again.
There was a question from Ido Benzvi. He asked, what about return to play, sport in general, and contact sports? So depends on how the child is doing after our first post-trauma visit. Usually we say avoid contact sports for at least 6 weeks. Because we know about repetitive trauma, even if it's mild, it might have deleterious effects on brain development and cognition.
Okay. So that needs a definition of contact sports again.
Yeah.
Okay. Further comments or questions? If not, thank you very much again. That was very helpful. And now finally, it's my pleasure to announce Alexander Yonzi. He's one of my chaps in our department. He's a young consultant in neurosurgery, and he's interested and published a lot about neurotraumatology experimentally and clinically. And he will now talk about mild TBI in the adult population. Go ahead.
Thank you very much, Professor de Berg, for the introduction. And thank you all for those great talks. I think many things have already been said. I'll just focus on the adult patient population, which is maybe a little bit different still than the pediatric one. So hope you can all see my slides. I mean, the general question is TBI in general and also mild TBI, is it even a problem? And if you look at the number of TBI patients in Germany from the Federal Bureau of Statistics, what you can see is that despite some thoughts that, TBI is not a major problem anymore, TBI is actually increasing about 38% in 15 years. And this really poses the question why, which patients are, where's this increase coming from? And we have looked at our own ED, emergency department visits related to TBI in the last years, and we have observed something similar. So since a couple of years, and overall within 15 years, there has been a substantial increase of contacts to our emergency department because of head injuries as well. So what kind of patients are those? We have taken those numbers and we have looked at all those TBI-related contacts to our emergency department in the last year for a couple of months, and we have prospectively collected them. And as you can imagine, those 975 patients in this little analysis, those patients predominantly have a mild TBI, 96%. So the main reason people come and visit our hospital is in terms of traumatic brain injury is actually due to mild injuries. And this increase, and we have looked at the data, and this is an increase in the last years for those mild TBI patients. This is probably reflected in the data from Germany that I have just presented as well. So mild TBI is on the rise. I think the previous presenters have spoken to the same direction. And because the scientific interest in mild TBI is also rising, I mean, there's typically a parallel direction. Right now, there are over 9,000 hits for the search term mild traumatic brain injury on PubMed. Because of those, this high scientific interest, we now have good prospective observational data on TBI in general, also on mild TBI. The Center TBI study has been named many times in the previous talks. In this study, 68% of patients had a mild injury. In the Chinese Center TBI study, so I think this has not been mentioned yet. So China had a sister study, a registry study, similar to the European Center TBI study, just bigger, a little different. And they had a rate of 56 mild TBI patients. And finally, the TRACK TBI study has already been mentioned. So the American predecessor, basically, they even had a rate of 82% of mild TBI patients. So those studies, they just prospectively enrolled TBI patients in general with one specialty. So in all those prospective studies, only patients with indication for brain CT imaging were enrolled. This means that those mild TBI patients that already are in most of those trials the highest study populations, they even got a brain CT scan, which is a small bias, and it also means that probably way more patients without the indication for brain CTs can come into the emergency departments of those hospitals involved in those studies, and the actual number of mild TBI in TBI patients is even higher. Real-world data on mild TBI, similar to what I've shown you from our emergency department, is quite scarce. There are, for example, 3 studies in the recent years. One is from New Zealand. They calculated the incidence of mild TBI in their country of around 749 inhabitants, cases per 100,000 inhabitants. So that's quite high number. Similar data from Norway, incidence little lower, and then data from the United States, of course, and there the number is a little bit higher again. So these are official numbers from some prospective registries and studies that look at all TBI cases, and they have these kind of incidence rates. So this obviously is a pandemic. The question isn't a silent one. I want to show you what a typical mild TBI patient, adult mild TBI patient might look like. The patient that, at least in Europe, in Heidelberg, you would see in the emergency department. So the patients that we looked at, they now have a mean age of 52 years. So that's one of the key messages also for mild TBI. Those patients are now older. Incidental falls, in our case, have been the majority of injury mechanisms. Road traffic incidents really rare with 5%. Loss of consciousness and post-traumatic amnesia. You can see the numbers here, not that much. Most of them have a GCS of 15 points. Anticoagulation, even in Mild Tbi patients, probably due to the higher patient age, in a substantial number of patients, 25%. And then this is interesting, in our cohort, we performed 66% of brain CTs, and nearly a third of those brain CTs showed some positive intracranial pathologies due to the trauma. And this is also interesting. You've heard these rates before. So the rate of those Mild Tbi patients undergoing neurosurgery is 3%. So this is a hint that mild does not necessarily mean mild, and that there is different complications in Mild Tbi. Just to show you the data from Europe, so in the Center TBI study, a cohort of Mild Tbi patients has specifically been assessed. And this just also shows you that the median age here is similar, and that the rate of incidental falls also is higher than the rate of road traffic incidents. Again, those patients all had a brain CT scan, indication for brain CT scan. So no wonder that the rate of positive brain CT scans is higher, is 48%. And those patients, because of their probably more complicated Mild Tbi, have been admitted to the hospital quite often. In the American study, they published a similar analysis on 2,000 Mild Tbi patients. Patients were a little bit younger. And this is really interesting. Although it's a Western country, the rate of incidental falls was, compared to Europe and to Heidelberg, was fairly small, just 27%. And the rate of hospital admission was even a little bit higher. So this just gives you different ideas of how a typical adult Mild Tbi patient currently looks like in Europe and the United States, and also in Heidelberg, if this is of interest for you. And I want to then touch briefly, let's say, a sub-cohort of Mild Tbi patients, the sports-related Mild Tbi patients. The video, just to warm you all up, shows some of those fairly terrible injuries. And although all of those will probably also be classified as Mild Tbi, even the one you've just seen, you can imagine that the actual injury in some of those cases, even with protection and so on, might be less mild than expected. So this is a big problem in the United States. In this cohort observational study, 4,110 adult patients were identified with sports-related Mild Tbi. In their calculation, the authors they say that this represents 1.3% of all TBIs in the country. And interestingly, equestrian sports had were the biggest contributors, contact sports the second biggest one. The authors also talk about chronic traumatic encephalopathy. I'll briefly touch this later on as well. And there is evidence that in those sports-related Mild TBIs, repetitive injuries especially might contribute to this neurodegenerative disease. And what is important for sports-related Mild Tbi is that when you have understood that it's a public health concern, you have to do what professional sports leagues did in the United States. Especially, they've launched initiatives to detect, prevent, and treat sports-related TBI, and they run a big campaign to increase awareness and also helmet use in many of those sports. The other subgroup of Mild Tbi patients are the military personnel, and this unfortunately becomes quite important in current days. And I think it is of interest for all of us to hear about blast injuries, mild traumatic brain injuries in this context. So interestingly, for soldiers, at least in the United States, Mild TBI is defined a little differently. So the GCS has no value there. They just rely on clinical symptoms, loss of consciousness for less than 30 minutes, alteration of consciousness for up to 24 hours, or PDA for up to 24 hours. So post-traumatic amnesia. And the blast injury is fairly well defined. So it is an even more complex injury than the typical injury you might see after an incidental fall. So there are more secondary and even tertiary and many more mechanisms involved. And the most important conclusion from this review published in Lancet Neurology in 2013 is that in the field for soldiers, diagnosing Mild Tbi is really difficult. Interestingly, there's a paradoxon in the field. Soldiers tend to downplay the symptoms, and then afterwards, when they are back home, they seem to experience those symptoms very intensively. So in the field, currently, I mean, this is for American soldiers, they use a standardized military acute concussion evaluation form. This can be done directly. It has to be done within 12 hours after the head injury. And they use it to triage patients to then get a subset of other diagnostic methods. It's not directly CT or MRI. It's interesting, the other things like eye tracking, like there's a gait measurement automated that they do, and then essentially a CT and MRI as well. It is also interesting to see how much research especially the American Department of Defense is putting into Mild Tbi, and they are obviously very interested in biomarkers and other diagnostic measurements in the field for their soldiers as well. And this is a study that even made it into the New England Journal of Medicine. The authors analyzed 2,525 soldiers deployed in Iraq, and the rate of head injuries with loss of consciousness was around 5%, and 10.3% had an altered mental status afterwards. And the authors also discussed that Mild Tbi among deployed soldiers is a big problem, because we'll see later on it is strongly associated with post-traumatic stress disorder, and brain injury and post-traumatic stress disorder together can create depression, and they are really important mediators for this relationship that I think military has discovered very early between Mild Tbi and even physical health problems. Now, you've seen those two subgroups of Mild Tbi patients, sports and military, but then again, the typical patient would now be probably an older person just having a fall. In any case, if you have a Mild Tbi patient, it does not necessarily have to stay a Mild Tbi. So some of those patients deteriorate, and even in the acute phase. And in this publication, authors did a meta-analysis, and they identified the following typical factors, I would say, that might affect the risk for adverse outcomes, even in Mild Tbi patients: higher age, lower initial GCS, and then type of injury, and the presence of anticoagulation. So this, maybe you can keep it in mind if you see Mild Tbi patients at a high age with a low, so 13 points GCS, and let's say a road traffic incident or a injury with substantial energetic force and anticoagulation. This might be a patient in risk for fast or further deterioration. Deterioration can be acute, but the main problem, and we've heard about it before, are those long-term sequelae of Mild Tbi, and there's a wide range of them. I have put some of them on this slide. So a lot of talk goes towards neurodegenerative diseases, and most importantly, the chronic traumatic encephalopathy. So you could fill a whole talk or maybe a whole day with data and with hypothesis on those two topics. So there is evidence that repetitive Mild Tbi is associated with the progression or the generation of neurodegenerative diseases like Alzheimer's disease, like Parkinson's disease, and then chronic traumatic encephalopathy is a unique neurodegenerative disease itself. Interestingly, Mild Tbi can also lead to autonomic dysfunction. Of course, it can lead to delayed intracranial hemorrhage. So those factors that I just previously told you, they mainly are used to identify patients at risk for delayed intracranial hemorrhage. There's interestingly insomnia, that a lot of people obviously experience anxiety symptoms and disorders. Then depression, very important post-concussive symptoms. So this is a group of defined symptoms that can be related to the mild traumatic brain injury. And then this can develop in a post-traumatic stress disorder, as has been mentioned with the soldiers. And another typical post-traumatic symptom, even in the long term, are headaches. And there's evidence now that those symptoms might be, for example, related to blood barrier dysfunction. The reason you can also hopefully detect mild TBI with biomarkers. And there's even evidence now that there's cortical spreading depression, so electric harmful activity in the brain after mild injuries. So all those are possible potential sequelae of mild TBI that make this injury not so mild. And therefore, it's important to manage mild TBI, I would say, appropriately. So Professor Neubeck asked this question before. In the acute phase, I think there are guidelines that can be used to overall manage those patients, specifically to indicate brain CT imaging. And also there are guidelines to safe discharge mild TBI patients from the ED, emergency department, or when you have admitted them from your normal ward. So you can look at those guidelines, and I think they should be implemented in clinical practice. But this is more interesting for us as neurosurgeons, at least. So what is coming next? So you had a patient, you identified no risk factors. He has no severe post-concussive symptoms, no long-term sequelae yet. So this is still in the acute phase, and you feel like you want to do something for him. I mean, later on in the future, there might be prediction models to tell you which patient really is at risk for one of those different symptoms I've just mentioned. So far, there's no such model, but this is what I have found in the literature, what can be done to improve the occurrence of those symptoms later on. So neuromuscular training and physical activity, this is cited many times, and this is published in smaller studies in a lot of cases. Then there is interdisciplinary group outpatient rehabilitation. So different disciplines joining together, patient groups rehabilitating together. This is mainly done in the United States. Psychological interventions at an early stage. Then there are studies on specific drugs for the problem of both post-traumatic headaches. And then there are studies on specific therapies like music intervention, vision therapy, and even neuromodulation as well. And I've said this before, the problem is that the evidence for those, let's say, non-pharmacological treatments for possible persistent post-concussive symptoms, the evidence is quite low. In this review, the authors try to define guidelines for the management of patients at risk for persistent post-concussion symptoms. And overall, they found really weak evidence. And so the recommendations are really weak for those interventions. Of course, early information and advice. So this can actually be done by the neurosurgeon in the first moment. Then graded physical exercise. So again, physical activity. Interestingly, vestibular rehabilitation, manual treatment of the neck and back, psychological treatment, and then again, this interdisciplinary coordinated rehabilitative treatment. So this is recommended, but very weakly and based on very low to low certainty of evidence, and mostly based on consensus of those authors. But it is interesting. It was interesting for me to read this as well. And again, in Germany, at least, I'm not aware of programs specifically made for this. But given this problem, the low functional recovery after mild TBI in some patients, I think it's, and the other presenters basically said the same before, it is very important to continue researching these treatments and to hopefully better implement them in our own practice. So this study, one of my last slides, assessed the
Yonzi,
yes.
it should be your last one.
Yes, they assessed the overall functional recovery after Mild Tbi. So this is not even some specific neuro score, some specific psychological assessment, just the GOSE score. And this has been done in the Track TBI study, and the percentage of Mild Tbi patients reporting functional limitations was 53%. This has been compared to a control of orthopedic patients, and the rate was lower. So this is a real problem. And just briefly, there is no way so far with the existing prognostic models that have been used to prognosticate TBI to prognosticate Mild TBI. So this basically concludes my talk. As you can see, there is much to study and to research, specifically also on prognostication, and I'm open for questions. Thank you all.
Thank you very much, Dr. Yonzi. Very interesting and many open questions, as you stated. Unfortunately, there is not much time, and I would, from the Q&A section, just briefly tell you that there is a good remark of Jack Barrett. Obviously, TBI is an umbrella term for a range of injuries. And this raises the question whether we are using the correct definition or we should look at something else. This is also a question to myself. But then there is a question concerning role of dopaminergic therapy in improving neurocognition. Can you contribute or comment, some of you? Is this an option?
It's not the one that I'm aware of, but I've read a couple of publications on different drugs that are currently tested. So this might be, in general, one of those pharmacological ways of addressing some of the symptoms that can occur after Mild TBI. But
okay.
Yeah.
Anything else you would like to bring to the audience or discuss in our resting 2 minutes?
With regard to the question you just asked, I have to say that most of the recommendations or treatment options for children are adopted basically from the adult setting, and a trial for children on medication would always go first through adult population. And this is also the problem with the kids, because many things we know about treatment in pediatric brain trauma is coming from adult patients and has to be reconsidered whether appropriate or not for children. So that's my comment at the end.
Thank you very much. Okay, it's time to close the session now. I would like to thank the presenters for 4 very interesting presentations. I would like to thank the audience. We had some 110 participants at maximum. Now, of course, people are retreating slowly. And in the end, I would like to announce that in July in Berlin, there will be the International Neurotrauma Society Conference meeting. And those of you who would like to get more information about Mild TBI, but also TBI in general, they are, of course, very welcome to join this meeting. Again, many thanks to all the participants and especially to the presenters. Have a nice evening. See you soon.
Thank you, Prof. Bye.
Bye-bye.